Operative pharmacological management of pheochromocytoma. Pheochromocytomas are rare catecholamine-secreting tumors arising from the adrenal medulla or extra-adrenal chromaffin tissue. They cause significant cardiovascular instability due to excessive secretion of catecholamines, epinephrine, norepinephrine, and dopamine. Perioperative management aims to optimize the patient for surgery, minimize intraoperative complications, and stabilize hemodynamics during tumor resection. 1. Preoperative preparation. Preoperative optimization is critical and typically spans 1 to 2 weeks. The goals are to normalize blood pressure, restore intravascular volume, and prevent catecholamine crises. A. Alpha adrenergic blockade, first-line therapy. Agents, non-selective AL blockers, phenoxybenzamine, long-acting, irreversible. Selective AL1 blockers, doxazosin, prazosin, shorter duration, fewer side effects. Mechanism. These block the effects of catecholamines on vascular A receptors, reducing vasoconstriction and hypertension. Titration. Start with low doses and titrate to achieve blood pressure control, 130 18 mm Hg, and symptomatic relief of catecholamine effects, e.g. sweating, palpitations. Monitoring. Monitor for orthostatic hypotension as a side effect. B. Beta adrenergic blockade, second-line therapy. Timing. Initiate only after adequate alpha blockade to prevent unopposed alpha-mediated vasoconstriction and hypertensive crises. Agents, propranolol, metoprolol, atenolol. Indication, used to control tachycardia, arrhythmias, or symptoms of catecholamine excess, e.g. tremors, palpitations. C. Calcium channel blockers, CCBs. Agents, amlodipine, nicardipine. Role may be added if alpha blockade is insufficient for blood pressure control or if alpha blockers are contraindicated. D. Metaricine. Mechanism. Inhibits tyrosine hydroxylase, reducing catecholamine synthesis. Indication, used adjunctively in patients with severe hypertension or symptoms. E. Volume expansion. Catecholamine-induced vasoconstriction leads to chronic hypovolemia. Intravenous fluids, e.g. isotonic saline, may be administered preoperatively to restore intravascular volume. Sharp 2. Intraoperative management. Surgical removal of the pheochromocytoma is often performed laparoscopically or through open surgery. The major intraoperative challenges are sudden surges in catecholamine levels during tumor manipulation and post-resection hypotension. A. Anesthetic induction and monitoring. Monitoring. Continuous intra-arterial blood pressure, central venous pressure, and, if necessary, cardiac output monitoring. Drugs. Avoid drugs that trigger catecholamine release, e.g. ketamine, ephedrine, pancuronium. Use short-acting agents like propofol for induction and dexmedetomidine for sedation. B. Management of hypertensive crises. Agents. Short-acting vasodilators. Sodium nitroprusside, nitroglycerin. Alpha blockers. Phentylamine, IV for acute hypertensive episodes. CCBs, nicardipine for stable control of hypertension. C. Arrhythmias and tachycardia. Agents, esmolol, short-acting beta blocker, or labetalol, A and beta blocker. D. Post-tumor resection hypotension. Causes include abrupt cessation of catecholamine release, persistent A blockade, and hypovolemia. Management, intravenous fluids, crystalloids, colloids, vasopressors, e.g. norepinephrine, phenylephrine. 3. Post-operative management. A. Monitoring. Patients should be monitored in an intensive care unit for at least 24 to 48 hours. Blood pressure and glucose levels require close monitoring due to potential post-operative hypotension and hypoglycemia. B. Blood pressure management. Persistent hypertension, managed with CCBs or ACE inhibitors. Hypotension. Continue fluid resuscitation and vasopressor support as needed. C. Hypoglycemia. Hypoglycemia is common due to rebound hyperinsulinemia after tumor removal. Regular glucose monitoring and supplementation may be required. D. Follow-up. Serial measurements of plasma urinary metanephrines to confirm complete tumor removal and screen for recurrence. Summary of pharmacological agents, class examples. Indications. Indications of plasma urinary for recurrence. Alpha blockers, phenoxybenzamine, doxazosin, preoperative blood pressure control. Beta blockers, propranolol, atenolol, control tachycardia, post-A blockade. Calcium channel blockers, nicardipine, amlodipine, adjunct or alternative to A blockers. Catecholamine synthesis inhibitor, metaricine, severe hypertension symptoms. Vasodilators, nitroprusside, nitroglycerin, intraoperative hypertensive crises. Vasopressors, norepinephrine, phenylephrine. Post-resection hypotension. Careful preoperative preparation and close perioperative monitoring are crucial to minimizing complications and ensuring successful outcomes in patients with pheochromocytoma.